Thank you. I'm going to pass on to my colleague Greg Clark with some questions for Jane Townson and Professor Oliver.
Thank you very much, Jeremy. Thank you, Jane, for joining us. We've talked about care homes. We talk a lot about the NHS, but of course the people that work looking after people in their homes have made a huge contribution over recent months. So I was wondering whether you just might share your reflections on what are the most pressing lessons that need to be learned for the home care sector.
Thank you.
Yes,
first of all, I want to start by paying tribute again to the home care workforce, because unlike many other professionals, they were there doing face-to-face visits with courage, compassion and care throughout, and I'm really grateful to them. I'd also like to reflect that overall, home care has proved itself remarkably resilient in COVID-19. The workforce have managed to keep people safe. A small study by Public Health England showed that home care workers had a similar prevalence of COVID-19 to the general population, and they've been very careful not to transmit that to people that they're looking after, even though testing has been very difficult to get hold of. And deaths overall in home care, whilst being higher than previous years, have actually been substantially lower than in care homes, because of course we don't have the congregate settings and there's less opportunity for transmission. So overall, we're proud of the home care sector and what it's managed to achieve. But talking to my colleague in Scotland, Donald McGaskill, recently, he reflected that social care feels as though it's treated like a Victorian child. And certainly the home care sector often feels as though it's thrown scraps from under the table of the NHS and care homes, and ends up with metaphorical rickets due to malnutrition. But unlike home care, Victorian children were at least seen, if not heard, and when they were sent out to work on minimum wage in Victorian factories, they were at least paid for shifts rather than by the minute. So we still have a long way to go to ensure that social care workers are seen as an integral part of the system. And listening to Helen and Teresa and Philip, they will testify that it's so important to have that additional support. And whilst many people haven't, Carers UK estimate that an additional 4.5 million people have become informal carers in COVID-19, taking the total to about 13.5 million. We've got just under 1 million, sort of 850,000 people being supported by formal home care. But the balance between formal and informal really needs to be looked at to ensure that everyone can keep going, because as Helen explained, puts pressure on the whole family. So I think our concern is that home care came into the pandemic with low status and in a weakened condition. The knowledge of home care and social care more widely in the Department of Health is quite weak. There isn't a fully collegiate approach to, for example, developing guidelines, and there's lack of clarity of accountability, so it was often very difficult when we had queries to find out who is actually responsible ultimately for making decisions on guidelines on PPE, for instance, because that is split between the Department of Health and Social Care, Public Health England, Health and Safety Executive, the Medical Devices Regulator, and so on. And I think we have a lack of vision. All we ever hear about is care homes and talk about people not having to sell their houses to pay for care homes. But altogether, there are over 15 million people supporting people at home, and only 500,000 people in the combination of care homes and hospital. The balance of conversation is in completely the wrong place.
Thank you.
And we need that vision to take us forward.
Thank you. So that's very clear. It's very helpful to understand. So your analysis is that the NHS, quite rightly, gets a lot of attention. You think that then there's obviously care homes, but you think domiciliary care settings get less because they're less visible. And I don't want to put words in your mouth. Is that a fair characterisation of your your
I
assessment?
think visibility is an issue, and just general lack of understanding of the social care sector. And domiciliary care is only a part, and Kathy will tell you there's also other parts of it too. Mental health and shared lives and other kinds of provisions that just haven't really been focused on sufficiently.
So, in terms of talking about a long-term plan, perhaps a 10-year plan for social care, do you think there needs to be a specific plan for the home care dimension of that?
Well, I think we overall need a vision and a strategy. For example, I mentioned before Norway. They've made a decision to enable as many people as possible to live well and safely at home. So let's start with having a policy, vision. And then, yes, we need to have a nationally mandated minimum fee rate for home care, so that as an absolute minimum, providers can pay the national legal minimum wage. We shouldn't even be having to ask for that. And as Kathy said, we need a workforce strategy. 1.5 million people work in the social care workforce. That's actually more than in the NHS. The NHS has a people plan. We have nothing so far for social care. But the tasks and the skills and the competencies that they have to perform are really complex. And now, as was mentioned, digital is being thrown into the mix as well. So we need, and people's needs are more complex. So we need to understand what skills, what competencies, what training, what standards we need, and then make it possible to deliver those.
Thank you. And specifically on testing, during the first part of the pandemic, could you say something about the ways in which your members managed, or perhaps didn't manage to get their hands on testing, and perhaps you might just say how it is now, and whether your members and people in the domiciliary sector are getting the tests that they need?
So home care was never on the priority list, and the reason given, the justification for that, was this small Public Health England study, which, whilst it may be true that the prevalence of COVID-19 in the home care workforce is similar to that in the general population, it ignores the fact that home care are supporting people on the high risk list by definition. Also, we have live-in care, where the care workers are actually living 24/7 with clients. And, understandably, those people want to be sure that the people coming in aren't infected. So we wanted asymptomatic testing. Now, in the very beginning, for people with symptoms, actually finding tests wasn't too difficult. But now it's become really difficult because more and more people have been promised tests. And once, schools have gone back and universities, it's very difficult even for people with symptoms to get tests quickly. And we still haven't made any progress on getting asymptomatic testing for the live-in care workers. And we would argue that in areas of local lockdown where transmission rates are higher, home care workers ought to be on the routine testing list as well.
Thank you, but we're not letting you off the hook yet, Professor Oliver, because I've got some colleagues who want to ask you some questions. So I'm going to go to Zara Sultana next.
My first question is addressed to Kathy and Jane. Just picking up on the comments that you made, that there's a lack of understanding about the care sector, there's a lack of parity, a lack of vision. And I wanted to ask you what your thoughts are on the announcements made by the government, where around £1.1 billion in funding for infection control in care homes in England has been announced. That was 600 million in May and another 546 million more recently to address transmission during the winter. Have the providers that you represent been able to access this money so far? And do you believe it's enough after a decade of underfunding for the sector?
Kathy, do you want to go first?
I go first, yes. I think any resourcing into social care is very welcome. I think, yes, absolutely, it will help. We don't understand totally with the Infection Control Fund at this moment in time whether that will be enough. We know that social care has been under-resourced for many years. We know that 99% of care homes are coming protocol. So we know that I
Sorry,
think.
Kathy, just a second. Could you repeat what you said? I'm sorry, there was typing, so I'm not sure if others were able to hear what you were saying.
I'm sorry, yes. 99% of care homes are completing their capacity trackers at the moment. There is a tremendous amount of data coming from care homes. Care homes are incredibly compliant around trying to look for ways forward and supporting the people that are supported within their care homes. So yes, they will utilise the funding where they can. There is obviously what caveats are against any funding, and we need to be able to look into that and understand that. I do not believe that is enough funding going into social care. As you quite rightly said, it has been underfunded for many, many years. I'll pass to Jane so she can maybe give a little bit more information.
Thank you. So as I mentioned earlier, home care entered the pandemic in a weakened position, grossly underfunded for many years, with only 1 in 7 councils coming anywhere near the United Kingdom Home Care Association's minimum price for home care. And just to give you an example, the increase in national minimum wage of 6.25% was announced on the 1st of January 2020. But by April, when it kicked in, very few councils had made any adjustments to the base fee rates to accommodate the extra costs of that. The first round of the Infection Control Fund, 75% of it was dedicated to care homes and 25% for other uses to be dispersed at council's discretion. Only 52% of the 25%, so about 13% in total, made it to any home care providers. We lobbied for that to be changed, and in the second tranche of ICF, the home care is included in the core grant in the 80%. But of course, now that's split between home care and care homes, and the amount that's been given is lower than previously, and it's got to last for longer. So we're not optimistic, all of us in the care sector, that will be enough. And the biggest cost actually is PPE, which is dealt with separately. And we very much welcome the PPE strategy that the government has laid out and the aspirations to provide free PPE. So the press releases are all about free PPE. At the moment, though, providers are unable to access the quantities that we're told they should be able to order through the portal, because there just aren't enough supplies behind the scenes. So that really needs to be addressed, because the PPE is at the moment the major additional cost apart from staffing.
Thank you both. Just linking on to some of the comments that were also made earlier around lack of PPE, which is something that, Jane, you've just touched on. Also the lack of testing, which has impacted the transfers from hospitals. Do you both have confidence in the government's test and trace strategy at the moment?
Unfortunately not.
Kathy?
No, I think testing has still got quite a way to go. The percentage of returns is still too low. It's improved for people on discharge, but not improved for the workforce. PPE has improved, I have to say, and it's really positive news that under 50 beds units are receiving free PPE. But as Jane said, we don't know what that means in the longer term. In the next 6 months, it's critical to have the stocks in place.
And just a few more questions. I've got 2 more questions. One is about the future of care homes, essentially. Analysis by Knight Frank estimate that occupancy levels across the UK have slumped to an average of 80% in mid-August. Are you therefore concerned about what this looks like in terms of care homes potentially having to close in the near future? And what does the sector therefore need in terms of support going forward after coronavirus? Whoever wants to respond to that.
I think more work needs to be done as well on the vacancy levels within the care homes, because obviously they are also looking at infection control measures as well at the same time. So I think some more analysis needs to be done of that data. My understanding is that there hasn't been an annual increase in the closures of care homes, but we are very mindful of the impact on care homes and the ability to actually see through the next few months. And obviously the workforce comes in there as well. There's been a tremendous impact on the workforce and the resilience of the workforce. And obviously, social care workforce has been running around 40% vacancy. That's before the pandemic. So there are some real risks around service continuity from the workforce as well.
Brilliant, thank you so much. And my final question to Professor Oliver, who talked about, again, low testing and how maybe the narrative nationally or the discourse was perhaps blaming hospital transfers for what we saw outbreak in care homes. I just want to ask you what NHS professionals felt in terms of potentially being scapegoated for such issues.
Yeah, I can't speak for everybody in the NHS, but I think I'm a doctor who works across the boundaries and has done care home work as well as acute work. I think in the acute sector at the time, we would have been thinking, well, what do you expect us to do, having watched other nations being completely overwhelmed, having modelling showing that acute services will be overwhelmed with a lack of access to testing, even for our own staff and even for sick people in our own facilities. I think the narrative in the mainstream media was simplistic, all kind of emotive language like people being abandoned to die and condemned to death. People need to remember that about a third of all care home residents die each year anyway, because they're a very frail cohort, and people on average only last about 18 months from admission. So these are people with any seasonal pandemic, people will die. So I think putting it all onto cruel acute hospitals being pushed by mean officials in the centre to discharge everybody untested was a simplification. I just think that we should have listened more to the sector, because it's not realistic to expect people without PPE and without testing for their own staff and with their own workforce issues to do isolation and infection control as a hospital ward would, especially when in half the cases they've not even been told the person has suspected coronavirus. But I think everybody's got scapegoated a bit, haven't they? More recently, the care homes have been scapegoated around visiting, but they have to have a clear dynamic risk assessment about allowing visitors in because of risk to visitors and other residents. And you should always imagine the counterfactual. What would have happened if we kept everybody in until they've had 2 investigations to clear them of COVID? What would have happened if they'd had unlimited visiting in care homes? That would have provided some poor headlines as well. So I think probably everyone's felt a bit got at, but fundamentally what Jane Townson said you should hang on to, there were underlying structural problems in the funding and staffing of social care, both in care homes and in people's own homes before the pandemic, but before they were invisible, even the care homes were invisible. And now at least we've got them in the spotlight. So I'd like to see the Prime Minister making good on his Queen's Speech promise to have a workable, sustainable cross-party solution to social care funding and provision by next year, and it shouldn't exclude unpaid carers who often short of support. And certainly we need more joined up working between health and social care. And I would be holding the government to account for delivery of the enhanced support for care homes component of the NHS 10-year plan, which is clearly in there as commitment.
Thank you.
Thank you very much indeed, Zara. Could you possibly put yourself on mute, Professor Oliver? Thank you very much. The Minister has actually arrived, but we've got some very important questions. If I could possibly ask Sarah Owen, Paul Bristow and Barbara Keeley to be brief to make sure we have enough time to ask questions to Helen Waitley. But Sarah Owen next.
Thank you, Chair. I'll be very quick. We've, as Health and Social Care Select Committee, have looked at staff burnout, and it's something that Kathy touched on just now about the vacancies for carers. And at the beginning of the year, that was sat at about 122,000. And I just wanted to hear from Kathy and from Jane, please, the impact this shortage of carers having on the sector, but also the people that are cared for, and also if there is an impact on the government's Brexit and immigration policies, and the rhetoric around it not being a skilled job, because anyone who has been a carer knows it is a very skilled job.
Do you want me to? Shall I go first, Kathy? In home care, interestingly, at the beginning of the pandemic, hours of delivery were actually reduced by about 6 to 10% for a couple of reasons. First of all, citizens themselves cancelled care visits because they were afraid of infection, and there were perceptions about inadequate PPE of care workers. And also, in some cases, councils cancelled care visits to create capacity for hospital discharge, which didn't happen at scale. So ironically, many of our members actually had to scale back recruitment because there wasn't enough work. That the volumes have now recovered and are actually increasing. Demand for home care is increasing, and that may be partly a reflection of people holding back before going into care homes, and also realizing that home care exists as well. Because there's been risks to jobs in other sectors like hospitality and retail, at the moment recruitment is quite buoyant. But we are concerned about how long that will last, because care isn't for everybody. You have to have a particular empathy and a particular sort of set of values, and it isn't for everybody. It's hard, it's tough work, it's emotionally tough and it's physically tough. We are concerned about migration policy. Whilst senior care workers have been put on the shortage occupation list, that still won't really make much of an impact. And we think that the government really needs to make an exception for health and social care workers with regard to immigration, particularly in the short term.
You're on mute, Kathy, sorry.
My apologies. Just to add to what Jane has said as well, is that service continuity has always been the priority for providers. So they have looked at how they have managed that with overtime, additional hours. Obviously, that adds on to the staff resilience. And I have to say the workforce has been absolutely exceptional. They've also been a point of contact for people who've been isolated in the community, and the provider sector has really stepped up over the last few months. The other thing I said is, I was going to say, will potentially have an impact is staff movement, and obviously looking about staff movement, because staff do quite often work within more than one facility, particularly care homes, and that could have an impact if that is restricted further. So I think it's something to be very aware of.
And sorry, just coming back to my point on staff burnout throughout this pandemic, have you had an impact, and how is it that can be best addressed? Because the problem isn't just recruiting carers, it's retaining them, as Jane had just mentioned.
Yes, it is an impact. There's a lot of organisations are putting a lot of time into their staff and their staff welfare, and look at what support's available for their staff. It's a difficult one. I don't have a direct answer to that. I don't know if Jane can answer it better than myself, but I think there's a lot of investment going in from organisations to try and support their staff who have continued to work really hard, and many have made massive sacrifices, like staff within care homes have actually moved into the care homes to support their residents, etc. So I don't think there is, I think there needs to be certain incentives for the workforce. There needs to be better pay for the workforce, as Jane has said, and we need to look at it further moving forward in that workforce strategy over the next 5 to 10 years. It's a crucial workforce that represents as many care and support as there is in the NHS. I
think there are particular pressures on the registered managers, and particularly in care homes. And it comes back to what David said about people being scapegoated. So, there are huge pressures of being accused of all kinds of things. And, providers are worried about litigation. They're worried about their residents. They're worried about families, either being able to see their loved ones or not as much as they would like to. And I think a lot of it will depend on how we as a system and as politicians and officials treat the investigations into all of this. That, certainly in Scotland, it seems to be quite harsh, and we're hearing about a lot of resignations of registered managers, and we really don't want that to happen. I think it's got to be done in a with an attitude of learning and with, as David said, putting things into context and considering, you know, what the alternative was at the time as well for people. So I think we can support our workforce by being understanding and by being gentle in how we investigate some of these issues.
Thank you very much indeed. And then briefly, if we may, Paul Bristow and Barbara Keeley with a couple of questions to wrap up.
Thank you, Chair. I'll be brief. I just wanted to declare an interest at first. My wife owns a communication consultancy with clients in the social care sector. I also just want to say, questions are to Jane. My father died during lockdown, and the care he received from domiciliary care workers was absolutely excellent. So I just want to place that on record and say thank you very much to the workers who looked after him and the sector as a whole. How would you rate the morale of domiciliary care workers at present?
Overall, I think it's not too bad, actually. There's a real sense of esprit de corps. You know, they pulled together, they've kept going, they have just carried on. I think it was very positive for them to be designated as key workers. And our colleagues in the Department of Health and Social Care had to fight quite hard for that to happen, so we really appreciate that. And for them, you know, they did receive more recognition. I think what we've got to make sure is that that doesn't vanish. And, you know, they were given more opportunities as well to perform tasks that normally other professionals like district nurses or even GPs might do. And what we don't want is, you know, when it suits those professionals to sort of take it all back again. We discussed that in the previous hearing, but my sense is that they're tired. You know, they're tired. Everyone's tired, actually, but still feeling positive and still feeling able to support people at home, and are pleased that the demand is increasing for that.
Well, that positivity is incredibly welcome. Just another question. To what extent do you feel the payment system that rewards, pays on periods of activity, if you like, rather than on something like outcomes, affects the ability of domiciliary care workers to do their job?
Well, it really upsets them because they want to meet the needs of the people that they're supporting. And it's very difficult to do that if the focus is on how many minutes you're there, as I discussed last time. I mean, to use the analogy that I used previously, you know, if an NHS trust said to a nurse, you know, we're not actually interested in whether your patient lives or dies and what happens to them. We're only interested in how many minutes you spend by the bedside. There'd be a collective tut-tutting. But unfortunately, that's what happens in the way that home care is purchased, but that's because there isn't enough funding in the system, and councils have had to come up with ways to try and make the money spread across as many people as possible. So what we need to do is address the underlying fundamental issue that the costs of delivering home care need to be properly covered.
Thank you. Barbara Keeley, is that all right, Paul? Barbara Keeley.
Thank you. I've got a couple of questions for Professor Oliver. I'm interested in looking back at what you said about the lessons learned from the what went wrong with rapid discharge into care homes. I mean, clearly, we're back in a situation we keep hearing now of pressure on beds, which will, you know, undoubtedly only escalate over coming weeks. First, what structural changes do we have to make to avoid that situation? I think you touched on where was the social care voice on stage? Where was the social care voice in national government? And certainly, as a committee, we've heard this again and again. And so the first part of my question is that, what can we do to avoid that happening again? What structural changes can we make? And also, you talked about enhanced support for care homes and, you know, things like oxygen, palliative care medicine. I mean, what we have heard from care home staff is that they didn't even have GPs visiting. You know, GPs were just using video links. So I think it would be difficult to try to bring an overstretched and tired workforce that we just heard about in care homes up to speed on, you know, the need for oxygen and palliative care medicine. It just seems like those are interesting things that you said, but how can we make those changes now that we you look back and they weren't there before, but how can we make them now?
Okay, so first thing about structural changes, most people who are delayed transfers from acute beds are not actually waiting for care homes. They're waiting for home care packages, or they're waiting for intermediate care, so out of hospital, rehabilitation and support in their own home led by health teams. In the early pandemic, because of the funding and the rules, we were able to get people out to those services more quickly, but the worry would be if there's no sustainable funding, they're saturated. So it'd be a very good thing to have more capacity in post-acute or admission prevention rehab services in their own homes, which again is part of the 10-year plan. And in some cases, doing that properly will stop people needing long-term social care. Care homes, yes, it's important to have general practitioners, and I know there's been something in the GP contract about named accountable GPs, but they need, whether there's a pandemic or not, to have access to the full range of healthcare inputs, whether it's physios or dietitians or speech therapists. They need palliative care so that people who are dying can die in situ. And in some parts of the country, there are really good teams that will go in there and give people short-term fluids and antibiotics. And I don't want to be criticising all of GPs, because there's some great examples where GPs spend a lot of their working week supporting care homes. So the models are there for all of those things, but they're patchy and they need to be the norm, whether there is a pandemic or not. Otherwise, you end up with people defaulting into acute hospital beds avoidably or being discharged without the right levels of support. And there has to be allied to proper advanced care planning. Anyone going into a care home needs a plan about what happens if they get sick, whether they get conveyed to the hospital, and yes, something we haven't touched on about resuscitation. If those plans are already in place, you won't end up with the kind of scandals we've had about imposition of DNA CPR. The bigger structural issue is who's involved in decision making at national level on SAGE, for instance. My perception is we don't have a really strong social care and care sector voice